My great honor to welcome you to our 2026 California Consortium for Cancer Health Equity Symposia. My name is Chanita Hughes Halbert. I am now a distinguished professor of population and public health sciences. I mentioned that because it was just announced, and I just want to share how proud and honored I am to have received this prestigious award. So just allow me to express my joy and thrill with that. But I also am the Associate Director for Cancer Health Disparities here at the Norris Comprehensive Cancer Center. And I also serve as the Executive Chair and Vice Chair for Research in the Department of Population and Public Health Sciences. I'm really excited to welcome you here today to our fourth symposia. And this has really been just a growth and evolution of the collaborative work that we do around in Southern California and across the state now to improve reduce cancer risk and improve outcomes among our different communities. So what I'm going to do is start us off by just giving a little bit of background about our consortia. This is something that was started about 4 years ago between City of Hope and USC Keck Medicine. And over time, we've really been intentional about enhancing and spreading our partnerships across Southern California. So we're now really pleased and excited to have collaborators from the University of California, Los Angeles, UCLA. Many of our community partners are here in the room today. So we really, such as the MLK Hospital. And what I'm really excited about is that we've been doing this work and growing our collaboration together with industry. So I'm really excited to thank and acknowledge the continued support of AstraZeneca. I'll go back and just so we can see all the slides. AstraZeneca and our new partner, still relatively new partner in the Ralph Lauren Corporate Foundation. So you can see all of our collaborators here, and you'll hear from all of us throughout the day. But this consortium has really been, I think, an important way for us to come together to collaborate across public health entities and residents, patients, academic health centers, community health centers, to really think about how we can sort of develop and grow our understanding to drive change and innovation across the state. So this year, we're focusing on lung cancer through patient navigation. And so why lung cancer and why now? So there's been a lot of movement and effort over the past year and a half to really focus on improving lung cancer care by addressing the key drivers of lung cancer disparities. So when California, I think we can all agree, is one of the national leaders when it comes to tobacco control. And we're learning more about environmental exposures. But I want to draw your attention to lung cancer screening because this is one of the areas where we continue to have important room for improvement to improve the way in which individuals access lung cancer screening, the way in which and how that can lead to and drive follow-up care and definitive treatment, and then as part of that, clinical trials. So this is why we're really focusing on lung cancer disparities, because I think we have an important opportunity and an obligation really to work to improve access to lung cancer screening in our area. We also know that there are some evidence-based approaches for improving access to care to addressing all the barriers across the continuum of cancer control. And so we continue to focus on patient navigation as part of this symposia because we know that there's a tremendous amount of evidence to drive it as its importance and solution for addressing multi-level drivers of cancer health disparities. One of the ways in which we know patient navigation can be particularly effective in terms of addressing some of the fundamental drivers that reduce access to care. It's also critical because it works at multiple levels, not at just the patient level, but it improves both provider knowledge, and it can be something that can be deployed across healthcare systems, regardless if it's at an academic center or at a community site. We still know, however, and you'll hear about this through some of the talks today, about ways in which we still have important opportunities to improve the synergy and standardization of how patient navigation is delivered across different clinical sites. So I'm really pleased to showcase our invited speakers. You'll hear from them throughout the day, but I just want to center our conversation at this point and share with you our symposia. So we built in a lot of time to sort of network and to identify opportunities to enhance cross-sector collaborations. You'll hear from folks who are leading some of the, I think, really innovative and exciting efforts across in lung cancer screening, lung cancer care, across Southern California. And along those lines, we'll hear from folks who'll share best practices for reducing access barriers. Ultimately, at the end of the day, I think I'm really excited about the conversation that we'll have that will help us think about how we can work together to drive innovation and patient navigation. So with that, I'm going to begin by introducing our keynote speaker. Rani Khetarpal is the president of the Academy of Oncology Nurse and Patient Navigators, who is an organization and through her leadership is driving the global conversations on navigation standards and workforce development. And as part of this, she ensures that the AONN membership base which is really extensive and has over 10,000 navigators globally, is supported in their pledge to enhance navigation. Rani is also CEO and co-founder of NavPoint Health, which is a healthcare organization dedicated to supporting navigators throughout NACI care, which is a digital platform that incorporates standardized navigation metrics and enables navigators to maximize their time and resources while keeping their focus on patients. She's an entrepreneur. I can't talk today. Excuse me, but she's a founding partner of Ravia Health Solutions, which is a boutique consulting firm that focuses on healthcare and life sciences consulting and fractional leadership with an emphasis on 0 to 1 GTM strategy and commercialization. So please join me in welcoming Rani to the podium.
Morning, everybody. First of all, thank you to Chanita and Trista for inviting me to be here with you all today. Really excited to be here, and one of the things that Trista and I were talking about is I always call the West Coast. I've always lived in California. I was born and raised in San Diego, and I've always worked for global companies, U.S. headquarters, always on the East Coast, but never moved. And I always call us the West Coast stepchildren because we never get the attention that we deserve for really everything. And so as AONN starts expanding their presence, and as I was rolled into this role last year, I was hell-bent on having a build in the West Coast and supporting our navigators here on the West Coast. And so I'm really excited to be here because see what we're doing? This is great. We have a West Coast office that I established late last year. And so now we can really support navigation here on the West Coast. So this is a great opportunity. So thank you for having me here. So I'm going to take a quick poll, and I don't do Slido because that's really complicated and all that stuff. So just old-fashioned raise of hands. How many of you are navigators, community health workers, social workers, oncology social workers? Raise a hand. Formally, okay. How many of you, keep your hand up. How many of you that did not raise your hand have ever helped a family member, friend, whoever in your life navigate the healthcare system? Yeah, y'all are navigators, okay? Let's be clear about that. So next time, everybody raise your hand. But it is a reason why navigation is really important. Those persons that raised their hand at the very beginning, they're trained to do this. This is what they're supposed to do, and they do it well. And patients deserve that. They deserve everybody's love and support, of course, but they also deserve every single one of those hands that raised at the beginning. And I'm gonna, clicker, here we go. I'm going to talk a little bit about Ingrid, and Ingrid is a very relatable story, I'm sure, to everybody in this audience. This is a real story, a real patient, personal to me. She's now in her late 50s, but she was in her early 50s during this, when the story first started. Ingrid worked 2 jobs. She spoke English as a second language. She had very limited resources, single mom, children, childcare, the whole 9 yards. She was late 2 years to get her mammogram done because she couldn't find time to leave her job because she's hourly, she didn't work, she didn't get paid. And so she finally made it a priority, got her mammogram. Results came in, they needed to do some advanced imaging, they were abnormal. It took her 4 months to go back in to get her advanced imaging test done. All the barriers that we are going to be talking about later today, throughout the day, delayed that next appointment. And then she received an email and a phone call letting her know that she had stage 3 breast cancer. That's horrible to get a voicemail and an email, and then please call our office to come in so we can talk to you about this. That was the message. So she did. And she went in, she sat down with her doctor. The only thing she understood is you have stage 3 breast cancer. She understood, she heard it, she didn't understand it after that. She freaked out. She called a friend who called another friend who called another friend who called me and said, can you help this person? She's freaking out. She doesn't know what to do. She doesn't even know what this means. Is she going to die? Et cetera. So we did the phone tree in reverse, and I said, have her reach out to me directly, and I hooked her up with some nonprofit navigation within her diagnosis area, which was breast cancer. She's great now. She's a survivor. She's 2 years, post, and she's thriving. But what if she didn't have the phone tree, right? What if that friend of a friend of a friend didn't know me? And that's inequity. That's disparity. That's not okay. And that's what we're trying to solve. And that's what navigators and patient navigation is here to do. Oh, I have a second thing here. I got to turn that off. All right, I'm going to go through a journey of navigation, past, present, and future. And I'm so sorry, I don't have a clock here. So if someone could give me like a 10-minute warning, thank you, and a 5-minute warning, because I can talk all day on this stuff. So the past, quote, I'd come to work, and what I trained to do, that's not the real answer. And that drove me to try to understand what was driving it. Poverty, the main issue, but also culture and behavior mixed in. And so I set out to try change this at one hospital in the beginning. That's all I knew to do. Anybody take a guess on who said that? Don't be shy. I heard a rumbling. What was it? Ah, good one. But no. Yes? Yes, Harold Freeman. Dr. Harold Freeman. Yay, Trista! Dr. Harold Freeman, otherwise known as the godfather of navigation. Dr. Harold Freeman in 1989 was president of the American Cancer Society. He was also a practicing physician at Harlem Hospital in Harlem, New York. And he realized that there was massive disparities in care and survivorship within the Black community and Black women specifically in his community. So we brought the community together, did some focus groups and kind of what's going on? What are the barriers here? And realized that a lot of them were functional barriers. They were just transportation. I gotta work, I got childcare. This is, what am I supposed to do? And so what he did in 1990, based on the results from that, is he decided he was going to set up a clinic every Saturday morning. And he would have a provider and he would have a navigator. The navigator was not a clinically trained navigator. They were not licensed. They didn't have any credentials. They were just community members who stepped up and said, I want to provide some peer support. But they knew the patient life. They knew the setting that they were coming from. They had familiarity with their journey. And so they can talk to them at their level. They translated what the doctor said. They provided assistance in understanding what their barriers were, right? Just had that dialogue with them. And that 5-year survival rate at the beginning of that project was 39% for the Black women in that community. The 5-year survival rate after the study period, which was I think about a year to 2 years, went up to 79%. Yeah, a huge intervention. That was the beginning of navigation and making health equity a focus of navigation. So in addition to Dr. Harold Freeman, we have 2 other wonderful women who are also considered founders of navigation. Linda Burhan-Stepanoff was working at the NIH and realized that there were all these barriers that are not being addressed, and went on to establish the Native American Cancer Research Corporation, or NACER. And they actually focused not just on identifying barriers, but removing those barriers. And so it's one thing to identify, but another thing to remove them. She also developed the first patient navigator record system in 2005, which is now labeled PNRS for short. I talk in acronyms, and Linda is actually my co-founder for NavPoint. And it was done because the NIH asked her to do it. So, but she always tells me that I talk in acronyms, so I apologize in advance, and she slaps my hand, but I do it anyway. And so her work was actually the foundations for some of the work that I'm going to be talking about later, are navigation metrics, as well as some acuity tools and professional standards of navigation, et cetera. Lily Shockney is our third founder highlighted here. She is now retired, but she was out of Johns Hopkins. And she was one of the first to actually put together a multidisciplinary team and document that. And do it in a very large health system that focused on a diverse array of patients. And very successful. And she also went on to be the founder of the Academy of Oncology Nurse and Patient Navigators. And again, very groundbreaking work that she did that really set the tone for what was to come in patient navigation. In the beginning, we had one definition for navigators. That was it. And this all probably looks very familiar to those of you that are very familiar with navigation, or even not, and trying to guess what navigation is. So this was in 1995, they put this out. We're in 2026. Is that 30 years later? It hasn't changed. It's still actually accurate. But the difference now is that we have 4 people doing the work of 1 person here, right? And that's ideal. There's still a lot of navigation programs that have 1 navigator and are doing all of this work. But in an ideal state, and what you'll see as we go forth, is that 1 person cannot do it all, and it's really important to have a team-based approach in navigation. And but that wasn't the case here. It was 1 person and 1 unilateral definition. In 2005, there was a $25 million investment made in patient navigation. It was actually the work of Dr. Harold Freeman and Linda Burhan-Stepanoff and the NIH and NCI that actually went out and lobbied for this money. And they got it. And it was to actually establish navigation sites across the country. And so you can see where that money was put. And again, I go back to the East Coast, very heavy on the East Coast. But we did have a few on the West and some in the Midwest as well, and the central states. But those were our first navigation sites. Now, if we were to actually populate this, I mean, there's still white space, actually. There's what I call navigation deserts across the country. So it's still not equitable across the country, but there are a lot more stars now, as we know. So the timeline, just really quickly from 1989 to 2012, it's weird to say that that's a history because it feels like 2012 was just yesterday, but navigation is still very young. And so we talked about 89 and 90 being the first navigation program. The Patient Navigator Outreach and Chronic Disease Act of 2005 was what awarded the $25 million to establish those first navigation sites. American Cancer Society also launched their first navigator program in 2005. That was the very first time that they had actual navigators helping patients through ACS. The NCI Community Cancer Centers program was established, and they actually included patient navigation as part of that, which was groundbreaking as well. And then in 2009, AONN Plus was established, which really created a home for navigators. And there's a lot that AONN was able to do moving forward. So that was a pretty instrumental association that started. And then ACCC, which is the Association of Community Cancer Centers, also created guidelines for patient navigation, really driving home the fact that even in a community cancer setting, navigation is really, really important. And then when we get into 2012, the Commission on Cancer, which NCI designated cancer centers are accredited by the Commission of Cancer, required patient navigation services as part of their accreditation process, and that happened in 2012. So again, another pivotal moment in navigation and the credibility that it brings to the patient journey. So the role of the navigator then, right? This is a toned down version of the bigger wheel that I showed you earlier. But at the time, in 2012, the navigator role went from being one to then bifurcating into two, which was the clinical nurse navigator and then the patient navigator. Now, a lot of people call that the lay navigator. I'm sure some of you still use that term here. AONN has taken a step forward and we've eliminated the term lay navigator. We call them patient navigators now. And then the oncology clinical navigator is a clinical nurse navigator. And we're trying to really drive home that terminology because the lay navigator is really a term that sort of was a slang term that stuck, but patient navigator is really the accurate term. So just as why that's in quotes there. There was no formal training requirement, but there was no certification or accreditation process either for navigators. I mean, there was hardly any education or resources, so how was there supposed to be any sort of formal training, right? So typically this is how it worked. Sally's on the floor working on the chemo floor, you know, as chemo nurse taps on the shoulder. Sally, we need you to go be a nurse navigator now. Okay. So now I'm a nurse navigator. What do I do? Well, nobody knows, right? You're just a nurse navigator because the COC tells us we have to have a navigation program, and so now you're a navigator. So that's when, you know, Sally goes to AONN and ONS and, you know, ACS and is like, well, do you guys have any resources? Well, yes, we do, Sally, welcome in. And so that's really how it starts. And honestly, that's still how it starts. A lot of our members come to us with exactly that same story, right? Well, I was told I'm a nurse navigator now, so, or I'm a patient navigator now, and I don't know what that is. I was an MA, so I don't know what to do, right? So it has evolved since then, but that was typically how navigators were brought forward. And navigation was definitely more of a nice to have. It was definitely not a need to have, it was a nice to have, it was optional. And we know that it's not optional, but it was optional back then. That was then. So what changed? Anybody? Huh? Okay, yeah. Correct. Yep. Also true. Yes, also true. All those things, and our healthcare ecosystem shifted. How did it shift? Anybody? Huh? Yes, absolutely. Big acronym here. Starts with the V. Ah, there it is. The V word. We saw a shift in 2012 start to happen. We're still very much fee for service, but we saw this term value-based care being thrown around. And then it was part of the Affordable Care Act. A lot of these things that VBC was born out of the ACA of 2010. VBC became the shift, good or bad, that was needed for patient navigation. It worked out really well for patient navigation. For the patient, jury's still out, but for navigation it worked, and I always like to say if it worked for navigation, it's working for the patient, so my selfish view. But we were moving from a fee-for-service to a value-based care model. Where does navigation fit in? So these are all of the elements of value-based care. Attribution. Attribution is very similar to what, in our terminology, a diagnosis. Is the patient fitting the model of value-based care? Are they able to participate in a value-based care program? Attribution is key to any successful value-based care model. Volume is the name of the game in VBC. So they want these patients in these models, but they have to qualify. Risk adjustment, how complex is the patient? Where does the patient live? What are their socioeconomic factors, their diagnosis, complexity, chronic conditions, comorbidities, all that kind of things. Risk adjustment stratification happens behind the scenes. It's a numbers game, really, really complicated formulas, statistician level stuff. Care management coordination, easily defined. Patient engagement, easily defined. Closing care gaps, improving quality, easily defined. Managing cost and utilization. So where does navigation fit in? Everywhere. This is why navigation became a thing. So what was great though is 2012 was the entree point, but it wasn't a static moment, right? It has evolved since 2012 and fairly rapidly. What was interesting though is the navigation world had no idea what was going on in the VBC world. It was just evolving on its own and it sort of matched up. And so by 2016, when OCM was launched, the oncology care model, and Medicare said, if you're going to participate in the oncology care model practice, we're going to give you $160 a month per patient as a service fee, basically an admin fee. So practice, and there was a requirement for patient navigation services in the OCM model. So you had to have patient navigation within your practice. And many of these practices, I would say a good majority of them, did not have patient navigation. So they took that $160 per patient per month, and they invested in building up a navigation program. That's where the funding came from, which, great, right? Like, awesome, yes, perfect, great solution. So they built up these navigation programs. And guess what? It worked. It worked. The quality metrics in OCM, there were 4 that were required for patient navigation. And those quality metrics, by gosh, they've knocked them out of the park. Because guess what? They had patient navigation. They had somebody dedicated to these patients. Now, OCM is one of those things that it may not have worked overall for the practice, but gosh, it really did work for patient navigation. That was a win. Now, what was sad about this is when OCM ended in 2020, and practices no longer had that $160 per member per month, well, the funding ran out. So patient navigation was something that was one of the first to go or got scaled down because there was no funding. So all of a sudden they had to find money to actually fund a program that they were getting revenue for. And that was a bit of a challenge. And so we saw this sort of de-escalation happen, especially in the community oncology setting. The bigger health systems really were able to shift some things around, but some of the smaller community practices, mid-sized community practices, that's where the real pain points were because they just didn't have the money to do that. And so the National Navigation Roundtable is put forth by the American Cancer Society, ACS-NNRT for short, when I talk in acronyms. They were launched in 2017. We started working, AONN started working on metrics in 2016, and we released 35 standardized metrics in 2017. It was a huge study that started in 2016 and ended in 2020 with a toolkit. But all of that work went into solving that problem of what's going to happen for funding, right? How do we actually assess ROI and standardize that across navigation so that we can then take that and build a case for funding for navigation? So while there was a downside to OCM ending from a navigation standpoint for some folks, it really did fuel some of the work that was going on behind the scenes to really establish what we call sustainability in navigation. What also happened during this time frame is certification for navigation. There was actually now formal training programs. George Washington Cancer Institute put forth their first navigation training program. It's Mandy Pratt Chapman spearheaded that, who's an amazing person, really dedicated to this. And there was a committee put together to build these core competencies and provide forth a training that navigators can take. That training still exists today. It is absolutely free. It's 100% online. If you haven't taken that training, even if you have an interest in what type of information is required for patient navigation, it's a great beginner navigation course. It's actually one of the courses now for those that are actually billing for PIN services. Those navigators can go through that training. So it's got some staying power, but that was released in 2015. AONN also launched an official certification exam, which required experience as a navigator. And what that did when we got accreditation for that certification in 2020 is, this might sound really simple, but navigators got to put letters behind their names, right? They're an oncology certified navigator or an oncology certified patient navigator. That meant something. It brought credibility to their role. It elevated who they were and really showed that, yes, I require training. Not anybody can do this at the level that I can do this, right? And that really was sort of the impetus for what came next, and we'll talk about that in just a minute. So principles of patient navigation as it stands from 2020 onwards, after all of that timeline. I'm not going to go through all of these, but these are all things that are in that wheel, right? But just to find down a little further, a little bit more granular. One of the couple things that is really interesting here is being cost effective. That was something that was not in the wheel. That came later, right? Because the fee for service to a value-based care model. Skill level, that came with the certification, resources, education, training that several organizations stepped up to help create. And then the navigating systems, I have issue with this term integrate, because I don't know if we can integrate a fragmented health. That's a really big task, to integrate a fragmented healthcare system, but we can certainly connect the dots. If we can connect 3-4 dots for a patient, then we're winning, right? That's a win. So now, instead of just one navigator, now we actually are recognizing 4 pillars of navigation. So you've got your clinical nurse navigator, which is your RN, typically your RN, your non-clinical patient navigator, which houses your patient navigators, your oncology social workers, et cetera, just non-clinical focused patient navigation, social determinants of health, barriers, things like that. Financial navigation, huge here, huge everywhere, right? Cancer is expensive. So that is a very up-and-coming subspecialty of navigation that we're putting a lot more energy, effort, resources towards. And then clinical trial navigation, which is typically defined as screening patients into a trial, getting patients matched up to trials. We're expanding that definition a little bit to keeping patients in trials, right? Navigating a patient through a trial. So not just letting them go, but working with trial coordinators to really identify proactively barriers to trial completion and proactively removing those barriers. It actually matches very nicely with the 35 metrics that were put out by AONN as well. Also, there were 3 organizations that came together and endorsed what's called the Oncology Navigation Standards of Professional Practice. We call them just professional practice standards. It was put together by PONT Committee, which there's the other acronym, right? Professional Oncology Navigation Task Force. It was a committee made up of key experts in all areas of navigation. All the different areas of navigation came together and put these standards together. It really provides very clear and concise direction and instructions and guidance to folks of what an actual professional oncology patient navigator, both clinical and non-clinical, should look like, and what are the standards that they should be adhering to. It's very comprehensive. It's open source. You can download this off the AONN website if you've interest. But it is a wonderful document that actually provides a lot of insight and really a roadmap of really elevating your navigation practice. It also was one that informed some other major timeline that I'm going to get into in just a second. In that standards of practice document, you'll find, really, I'm not going to go through all these bullets, but you will find very concise definitions of these roles and what it means. There's financial navigators, clinical trial navigators are lumped into these 3 segments. but it is still mentioned and very much defined out in the document. So really helpful to have that and to use that as you're building and scaling your navigation program. All right, so inflection points of the present. So these are huge, huge advances. The field, I'll say right now, not that it never has had a moment, navigation is having a moment. Like you can't go anywhere without somebody saying navigation, right? That's the thing. It was like what BBC was like, you know, in 2015, 2016. This is like the buzzword of the moment. And for good reason. It has since 2022, the last 3 years or so, it has really taken hold, and the fire is burning. The fire is burning really hot in a very, very good way. So Cancer Moonshot was reignited under the Biden administration, under the Biden Cancer Initiative. Jill Biden was a huge proponent of patient navigation and really made that a mission of hers during her time at the White House. And in 2022, started the work on building what's now known as the Principal Illness Navigation Codes. And in 2023, they announced that they have the codes and that they will be utilized starting January of 2024. I cannot stress how impactful this is. What this is going to do for patient navigation moving forward is astronomical. Now you can actually bill for navigation services. Navigators get reimbursed for their time with the patient. They get reimbursed for the time for documentation. They get reimbursed for their time for coordinating care. They get reimbursed for their time for behavioral health and talking to their patients about their behavioral health issues. They get reimbursed for their time for setting up services and doing resource research, right, which is a lot of time. You get compensated for all that time now. It's unbelievable that this happened. I mean, we've been lobbying for this. Many organizations have come together and lobbied for this for years. And so that happened in 2024. We also, in this year, AONN is releasing the first ever digital acuity tool to assess patient acuity, to be able to properly categorize patients, and a lot of implications downstream: caseload, avoiding navigator burnout, workforce, staffing considerations, all of those things. And that release is coming up here in actually just a couple months for phase 1, so it's very exciting. So launching deeper a little bit into the PIN codes, you can be just a patient navigator, you can be an oncology social worker, you can be a financial navigator, you can be a clinical nurse navigator and bill for your time. You have to bill under a provider, you have to be under an NPI to do this, and it's not just cancer, it's all 21 HHS recognized chronic conditions. So the PIN codes now are being used in heart failure, in diabetes navigation, in CKD navigation, you name it, it's being used. So this is great because it's not just affecting cancer, which is fantastic. There's 2 primary codes and 2 separate what I call kicker codes. It allows for continuous billing within a calendar month. So every minute of your time is compensated. It's not a finite amount of time. Which is, again, fantastic. We all know as navigators that, you know, you could be spending 60 minutes with one patient and 400 minutes with another patient, right? Like, let's be honest. So you're going to get compensated for all that time, which is great. Not going to go through this. This is just an overview of both of those codes. If there's interest in this, feel free to take a screenshot, but I think the slides will be available, right? So, all right. So I know I have just a few minutes left, so I'm gonna just kind of speed through these, skip through that. These are super interesting statistics around health inequalities that exist in cancer incidence and mortality. It goes over the disparities between Black and whites and why this is so important to ensure that there's equality in care, and navigation is such an important part of that. A lot of this, as you will see, is that a lot of this has to do with early detection, prevention, and screening, right? I probably said that in reverse. But that is really the crux of this. If we can get these populations educated on preventative care and risk factors, and then get them in screening to get them early diagnosed, these percentages are going to equalize and go down. And that's the goal here. This is interesting information. This was a report on cancer that was done in ACS in 2025 statistics. 26 has not been released yet. But we're talking about lung today. It is the second highest cancer incidence out of all the cancer types. So it is good that we're talking about it. And it affects both men and women, whereas the first is prostate breast, right? But lung is gender neutral. And so it's really important that we talk about that as well. The 5-year survival rate over time, I thought this was interesting as well. The good news is that we're making progress. And the bad news is that I think we can make more progress. Breast has really done well, right? But there is still a lot of work to be done in lung. And that's our subject today. So I'm glad that that is where we're at and what we're talking about. 5 years relative survival rate by race. Again, going to just skim through this. The takeaway here is that there's still a higher incidence of survival rates in whites versus blacks. And you can say that reverse too, is that there is a lower incidence of survival rates in blacks. So again, really, really huge disparity there that we have to normalize and we have to equalize there. It would be great to just bring that red bar up, right? We don't want to bring the blue bar down. We want to bring the red bar up. But these survival rates that have increased over time have really paused to say, what is survivorship and how do we navigate through survivorship? So survivorship is a really key area of navigation. A lot of resources are being put forth towards survivorship. Does anybody know when survivorship starts? Yes, yes. Sorry, I didn't mean to do that. I got excited. It's diagnosis plus day one. And so it doesn't start after they're cancer-free. It starts when they're diagnosed. And so their challenges, their needs evolve over time. And of course, there's different challenges when they are in cancer-free survivorship. And so the clinics that are popping up, the education that's popping up is actually very encouraging in that space. Current state of navigation, we're not going to have enough navigators to support the needs. That's just a fact. So currently only 1 in 2 patients ever touch a navigator. About 20% of those patients ever see a navigator more than once. And if I see a navigator and Chanita doesn't see a navigator, I have a better chance with the same exact cancer type, same socioeconomic backgrounds, everything. I have a chance of a better outcome than she does by about 40%. It's not great. It's not great. We've got to fix this. The one way to fix this, I was going to do a poll, but I'm not going to for sake of time. Sustainability. So sustainability is a thing, and it's something that we have been working on at AONN as well as NNRT to really put forth some criteria around sustainability and looking at that. So we have a patient navigation sustainability assessment tool, again, downloadable off of the AONN website. There's 8 domains there that you can work on to ensure that your navigation program is sustainable. I'm not going to go sake of time go through these bullets, but I will just say one thing. As having been an administrator in a provider organization, make sure that you have your leadership support in everything you do. And the way to do that is continuous dialogue and ROI. Both qualitative and quantitative storytelling is great, data's better, right? Make sure you're able to capture data. Use the metrics to develop that KPIs. Don't ever pick 35 metrics to do all at once. Pick 1, pick 2. There's 7 domains, 35 metrics. Pick a domain and pick 1 to 2 metrics in that domain. Maybe if you're a larger program with different diverse navigators in there, pick 2 domains and 3 metrics. But that's what you have to do. Focus on those metrics 6 months, get the data, go to leadership and say, look what we did. That's how you get that support. I'm going to skip that for technology, just really quickly talking about technology. We talk a lot, AI's everywhere, right? Technology's everywhere, got to have technology. I would say about 85% of our members still document in Excel and still document by hand because they use Epic and they use Cerner and they use all those things to document their interaction, but their true data on what they're doing for the patient sits here and in Excel, right? It's got to move away from that. So the PNRS platform that Linda Burhan-Stepanoff first developed in 2005 that has evolved over time is one example of that. There are others out there. But it is a focused, navigator-specific documentation tool that is integratable with all the big EMRs. Even if you're using the big EMRs, use your EMRs, use your tools that you have in front of you. Epic has barriers that you can actually go into. You have to build them, they're custom. But we are working with a health system in the East Coast that are actually doing that within Epic. It took her almost a year and a half to build it. But she built it, right? And so it's great. Or you can plug and play, but do something, get it off Excel. Data will empower sustainability. What I will say about, because I get asked this question because I'm in tech, is, well, I have an AI, navigation AI. So this is interesting because I'm president of AONN and I have a tech company. And so I hear the folks that come to our members and say, well, we're doing AI and navigation. And I just kind of stand back and I'm like, let me hear this, right? And so they're like, well, yeah, we're doing this and we're doing this. It's not AI, it's automation. They're automating workflows. And that is very, very important. Let's not discount that work. It's very important. Automation will increase efficiencies. But true agentic AI doesn't exist because the data doesn't exist. Navigation data does not exist right now. It will, but it doesn't exist right now. They say in AI, crap in, crap out, right? That's exactly what's going on there. So if you have a chance, I highly recommend, if you're interested in technology and navigation, this was put forth by the President's Cancer Panel in 2025 released, but it was put together in 24. It's probably outdated by now. But it's got some really interesting discussions in there and points some things out about technology and equity in cancer care. So I highly recommend that. So hungry for more? Our AONN, just a shameless plug, AONN mid-year meeting is here, guys. Yay, thank you, thank you. It's always East Coast, always. But I was like, nope, we're gonna do it here. Support me and come, because I told them we're gonna get our local community. It's here at the Bonaventure Hotel, April 15th through the 18th. There's also a virtual as well. We're giving 10% to everybody here if you'd like to go. It's not expensive to attend. You get 1 year membership free to AONN with your attendance. It's a wonderful, wonderful conference. We dig really, really deep into all of these issues that we talked about and then some. It is a member-driven conference, so they pull together the content, et cetera, and it's a great one. And I know some of you are coming, and I appreciate that, but it's going to be great. And with that, I'm going to leave you with this quote and questions. I don't know if we have time, but yeah. I just rushed through that last like 10 minutes.
We have time for a few questions. Does anybody have a question?
Good morning. Thank you
Hi.
very much.
Yeah.
That was very informative. I just have a quick question. Have you heard of any payers that deny the claims for the navigation? I know CMS did the claims, but I wonder if you've heard of any situations where there's specific or payers that pop up that don't recognize this.
So that is payer by payer. And that anecdotally, I've heard that there are some commercial payers that are reimbursing currently. It's at their negotiated rate with the provider. So that is something that the provider in their contract would go through and say, Hi Blue Cross, I'm going to be billing for navigation. It's covered by CMS. I just want to make you aware that I'll be billing it. And they'll either say, yeah, okay, whatever, or they will have a discussion with you on it. If you just bill your commercial payer and just hope for the best, it's, playing darts in the dark. It's hard to tell right now. It will take, the typical runway for commercial payers to follow suit with all the Medicare stuff is about 3 years. And we're in year, 2 now. So 24, 25, we're in year 3. So hopefully by the end of this year, anecdotally, I'm hearing that is starting to happen. So I don't know names of payers, but for those of you that are curious, Medicare fee-for-service, commercial Medicare, so Medicare Advantage plans, and dual eligible patients, and some state Medicare will cover it as well. So those Medicaid, state Medicaid and managed Medicaid plans will cover it. So that's your payer base right now, for sure.
Thank you.
Yep.
We have time for one more question. Does anybody else have a question?
We're the popular table. I'm just curious, so with the reimbursement, are you seeing an uptick in more navigation programs that maybe were cut coming back online? And do you see more adoption of it over time?
Adoption of the PIN codes?
Adoption of the PIN codes and just saying, okay, yes, we're going to invest in navigation overall.
The short answer is yes. The longer answer is there still needs to be, if your program was cut, you've got to start your program somehow. And typically that's being done right now through grant funding. So as those grants run out, which is happening now, right? Typically they're about 3 to 5 year grants. We are seeing more people getting curious about, well, I got to set up my PIN billing, right? Because that's now a source of revenue. So, and not just for programs that are established, but also programs that are current and are looking to scale their program. They're seeing the PIN codes as an opportunity to actually self-fund the scaling of their program. So, yes, yeah. Okay, thank you all, appreciate you, thank you so much.